I want to welcome everybody to a webcast by Columbia Psychiatry and Columbia University Medical Center over the summer on topics related to the COVID-19 pandemic. And I'm Jeffrey Lieberman, Chair of Psychiatry and Psychiatrist-in-Chief at New York Presbyterian Hospital, Columbia University Medical Center. And I'm pleased to be joined for today's discussion by my colleague, Linda Rosenberg, who is the Executive Director for Government, Media, and Community Services. That's a mouthful. Linda, in addition to being a social worker who had been in the New York State Office of Mental Health, serving as Deputy Commissioner, is the immediate past President and CEO of the National Council on Behavioral Health, which is the largest organization governing or overseeing the community-based mental health clinics in the United States, and has done an astonishing job at really increasing the impact and the quality of mental health services in the country. And when she saw fit to step down into our role, we immediately approached her for coming on faculty, and she's joined us since last year. So Linda, welcome.
Thank you. It's a pleasure.
And our other guest is someone who has, equal renown and has been in much demand of late. You've probably seen her on any number of cable news programs, particularly CNN, Dr. Patrice Harris. Dr. Harris is the immediate past president of the American Medical Association, but that's not where she started out. She hails from West Virginia and received her medical degree from West Virginia University School of Medicine, and then did her postgraduate training in psychiatry at Emory in Atlanta, Georgia, where she completed her general psychiatry, child psychiatry, and also did a forensic psychiatry fellowship, and worked for a number of years in the public mental health system of Fulton County, eventually moving from mental health to heading the Department of Health Services for Fulton County, and extending her scope of involvement and experience outside of psychiatry to medicine in general. And that was clearly a stepping stone to her role as AMA president. Timing is everything, and her presidency occurred or overlapped during the period when we had the COVID-19 pandemic, followed by the social unrest related to the racial injustices and all of the economic and social disruption that's associated with these. So Patrice certainly earned her salary or whatever stipend she received doing overtime with respect to her AMA responsibilities as a spokesperson on health and social matters. So Patrice, welcome, and thank you for joining us.
Well, thank you, Jeff. It is so great to be here with you and Linda, and I really appreciate Columbia Psychiatry for putting on this webinar today. And I consider it the privilege of a lifetime to be in the right place at the right time during this past year.
Good. We also are fortunate that you were. Well, at this point, my job is done. I'm going to turn it over to Linda, who will serve as the moderator for this discussion and speak only when called on.
Thank you both for allowing me to talk with you today. Our title is Mental Health Effects of COVID-19 on Communities of Color. And I have a set of questions I'm interested in asking both of you. And additionally, we got really a huge number of questions sent in. So we have until about 12 o'clock, that's our hard stop. And so I'm going to ask both of you to be relatively brief so we can get in as many questions as we can.
I realized that I omitted mentioning the fact that we do, Linda, have closed captioning. So we have closed captioning for people that would like to have the printed word as well as the spoken word, and it's available in both English and Spanish. So you can cursor down to the closed caption icon at the bottom of the screen and activate that if you want.
Thank you so much for doing that. So Dr. Lieberman, let me start with you. You're my boss, and I'm a big admirer. And I've heard you say a number of times that the COVID-19 crisis is going to have a generational effect, as the Depression did. Can you explain what you meant by that?
Well, we all have flashbulb memories of the disasters that have happened in the past, whether it's Hurricane Sandy or 9/11 or the Challenger space capsule or President Kennedy's assassination, for those of us who are old enough to have lived then. But those were time limited and geographically limited. This is something that is clearly unprecedented in our generation and is pervasive and enduring. And it's not just the contagion of the virus and the social isolation and the fear of getting sick or losing loved ones. It's the also social and economic disruption that's going to occur and is going to be enduring long beyond when we have a vaccine and the contagion of the virus has been limited. And we see how it's affecting us now, just in the fact that our lives have been totally turned upside down. Our kids can't go to school. We're not able to socialize. Many people are experiencing economic hardship because they're losing their jobs. And we don't know the extent of it. We don't know how long this is going to go on, how bad it's going to be, and when it's going to end. And this is going to have an enduring effect in a variety of ways on different demographic segments of our population. And it would behoove us from a public health standpoint to anticipate this and enact initiatives that could preempt the dire consequences.
So Dr. Harris, we know that Latino and Black Americans are 3 times more likely to be infected by COVID and twice as likely to die from the disease. What are the causes? And is it what we've euphemistically called the social determinants of health, or is it also racism and just a different kind of attention?
Well, certainly this current pandemic has brought into stark relief so many issues that were pre-existing, if you will, prior to the pandemic. And those include the long-standing underfunding of our public health infrastructure, the long-standing underfunding and under-resourcing of our mental health infrastructure, and certainly the long-standing complexities of health inequities in this country. And certainly it is a complex set of factors that are leading to the disproportionate impact. But I think it's important that we begin from the beginning, right? We have to start with what others have written. We have to start with the causes of the causes, right? And candidly, we have to be unrelenting in our commitment to naming those. And so, yes, it is about the structural determinants of health, those societal and institutional norms, policies, and practices that have led to those social determinants of health, right? Housing, education, where you live, work, and play, whether or not you live in a food desert, whether or not you have access to adequate health care. So yes, absolutely, those structural institutions and norms do include racism. And I think it's important that we name that as we begin to even think about solutions that will move us forward.
So, Dr. Harris, statistics are powerful, but I've heard you talk about the power of narrative medicine. Could you explain to those of us who don't know much about that, what you mean and how you think we need to use it to continue the focus on these disparities and on racism?
Absolutely. And first and foremost, again, the data is very important, but it's sufficient. It's necessary, but not sufficient. And I believe that there's so much promise in better understanding our patients if we focus on narrative medicine. So what does narrative medicine mean? It's just an approach simply to understand the stories of our patients. Again, if we're talking about medicine, we should understand stories in so many factors. But as we talk about medicine and healthcare today, it's really an approach, again, that uses people's stories to further understand their current health. It is critical that we not just focus on the chief complaint, what brought you in today, but we also understand what brought you in today from the perspective and through the lens of our patient's lived experience, which are unique. Actually, each patient has a unique lived experience. There are some similarities in certain demographics, but we really want to make sure we understand that unique lived experience through that N of one that is in front of us. And then if we want to understand communities, we have to understand the narratives and the stories and the lived experiences of communities. And certainly I believe that by better understanding those stories and narratives, we can, it will make us better physicians, clinicians, social workers, nurses, health professions, and our patients will believe they are listened to. And that is so critical. They will believe that they are listened to. And that is a great foundation for moving forward and improving health and improving healthcare.
Thank you. Dr. Lieberman, you certainly understand that this is a difficult time. You've been running, a hospital and an array of services during this time. But I know you also think this is an opportunity. I've heard you say that as a faculty member here. Can you talk about what you would hope to see both internally as well as in the communities we serve?
Well, and the aphorism, never miss an opportunity, I think gives psychiatry one here. And if there are any silver linings in this otherwise catastrophic situation, it's that the role of mental health and psychiatry and mental health providers is going to be more and more necessary and probably more visibly sought after and identified. And that's because, one, during the crisis, people under stress have greater need, but also what we've seen is that the healthcare providers, so ordinarily in a workplace, whether it's an office, whether it's a factory, whether it's a retail store, or whether it's a hospital, there's HR services, but there's not kind of ongoing, daily, or regular kind of mental health related support resources that are in place and being provided. It's only if there's a need, when you're sick or when you're symptomatic. But in the context of the COVID pandemic, we've seen the stress that has been placed on frontline healthcare providers, particularly the emergency rooms, the ICU, the medical units, but really all aspects of the hospital. So there's a role that immediately we are called to play in providing ongoing professional support and stress management. But beyond that, the communities initially are resilient in responding to this, coping, bearing up, adapting to the unusual circumstances. But as this wears on, and as the long-term consequences become apparent in terms of loss of jobs, closing of businesses, a change in the different patterns of life, where you're not on site, you may be working from home, or you may be only working part-time. When kids have missed a block of their social development and educational development, these things are going to impact the collective mental health, indeed the collective psyche of communities and populations. And we're going to be necessary to try and advise and provide efforts to try and remediate or preempt these things. And that's why I think the opportunity that would be ideal is to see this as a calling for a public mental health initiative that would really be population focused and adapted to the needs of local communities, because the needs, like in Northern Manhattan, where we mostly see patients from, we're dealing with people from Harlem, from Washington Heights, from the Inwood and from the West Bronx areas. And each of those have different cultural characteristics. So this is a time to basically conceive of this broadly focused public mental health initiative and to adapt it to the communities and to do it in partnership with the communities. And I hope we'll take advantage of it.
So you've led us really in creating a model that could implement what you're describing. What do we need to make it happen?
It's a leading question. Money.
That's it.
So Linda is referring to the fact that at the request of the political and community leadership of the different communities in Northern Manhattan, we were asked to advise as to what's going to happen, what are the needs going to be, and what could be done. And based on that, we've developed a program for what we're calling a Northern Manhattan Mental Health Initiative, which is exactly what I was referring to before as a public mental health initiative focused on the needs of the population in the context of this crisis. This has been presented with the various political leaders, congresspersons, assembly persons, city council persons of the different districts, and also 2 weeks ago presented to Mayor de Blasio, and really does in many ways follow the inspirational public mental health effort of his wife, Charlene McRae, with Project Thrive. And at the end of the presentation, the mayor says, "So that sounds fantastic. I'm all in. What do you need from me?" And I said, $15 million.
I think the other thing I would just add is this initiative is designed to work closely with all the existing community clinics and hospitals in the area. This is really a shared responsibility. So now I have another question, and that is, I think I'd be remiss if I didn't mention that yesterday we had an announcement of the vice presidential nominee on one of the tickets, Dr. Harris. I've learned no relation that we know to Patrice, but now that we know both tickets, what would each of you hope would be the message around mental health that those two campaigns would articulate often? So can I start with you, Dr. Harris?
Absolutely, and yes, no relation to the senator as far as I know, but certainly, and I want to make it clear, I am still on the board of the American Medical Association as immediate past president, and the AMA is nonpartisan. And we actually have always been willing and have always worked with both parties to advance our mission, right? The art and science of medicine and the betterment of public health. But on a personal note, Senator Harris is a member of my sorority, Alpha Kappa Alpha Sorority Incorporated, the first African American and Asian American woman to be on a major ticket, and so and I am the daughter of I'm the proud daughter of an HBCU grad, and so certainly on a personal note, I am proud. But here is what we always have to remember, as I said earlier: health and the health of the public is nonpartisan. It really should be. It has to be. We have the data. We know where we need resources, as Jeff said, and I'm going to say a little bit about that in a minute. And so, my message is, let's look at the data and let's commit. Many folks are making statements about their level of commitment. But as I say, that is wonderful. The AMA has made statements as well around our commitment to health equity, but we have also put resources behind the commitment. So it really is not just about asking for money, but it is about what I say, and I've said to Jeff, and I think you, Linda, about a commitment of purpose and accountability. And, it does require resources, especially when it comes to mental health, because we are starting so behind the 8 ball. So I would say, let's join with us. Let's make the commitment. Let's make sure there's accountability. Let's make sure we put the resources and partner with our communities to improve the health of those in our country, and make sure that there are no health inequities and that everyone has an equitable opportunity to achieve their optimal health.
Well said. Dr. Lieberman, what would you like to hear from the tickets?
Well, I think that it would be extremely gratifying and reassuring if the campaigns, both campaigns, recognize the fact that addressing mental health is the low-hanging fruit for a successful initiative of their administrations. And what I mean by that is mental health, for a variety of reasons, has been uniquely disadvantaged and a kind of a second-class component of healthcare historically, and continues to be the case. And it's relevant for so many ways. First and foremost, in terms of the fact that from an economic standpoint, the country, the government is worried about how it finances healthcare, how its healthcare policy is structured. And in that context, they're worried about the rising cost of healthcare, because as medicine advances and we can do end-of-life care, organ transplantation, people are living longer, the percentage of the GDP accounted for by healthcare expenditures is increasing and approaching 20%. Whereas in the 1960s, it was like under 5%. And if you talk to any health economist, they will tell you that mental health is the secret sauce of cost containment and efficient healthcare expenditure. So it pays economically to pay attention to this. But in addition, the social ills that really get the public's attention of homelessness, of suicide, of addiction, of individuals, and this is a small proportion of violent crime, but it's the ones that get the headlines, individuals who have psychotic disorders or severe mood disorders or are untreated, do engage in the perpetration of violent crime on a mass level. And mass violence is something which is just abhorrent to people. And these are correctable problems. Also, our prisons have increasing numbers of people who are mentally ill. They're mentally ill and they may be potentially great citizens, but they're bad crooks, and they get caught and they get put in jail instead of being treated. And if they had been treated to begin with, they probably wouldn't have committed the crime. So it's these social pathologies which would benefit from that. So in my recollection, the only candidate who has ever really identified public mental health as a priority as in their platforms during the campaign was Hillary Clinton. And she released in 2016, prior to the election, a white paper describing her proposal on a mental health initiative. I would like to see both administrations do the same thing this time.
Good suggestion. You both of you want to nurture diversity in the physician workforce. Could you tell those who are tuned in or will listen to this recorded version, what's one thing we could do to make that happen? Could each of you come up with one concrete example that we could do right away, in fact? Dr. Lieberman, you want to give it a shot?
Okay, well, I can tell you that there's several ways to go about it. One way that I think is really extremely promising is starting early. In other words, if you look at the numbers in terms of ethnic, racial, gender diversity across students, it's good. And then when you look at graduate school and at postgraduate school and at the assistant professor or associate professor, professor leadership positions, it begins to change. So if you start early, you find that there's a lot of people of different ethnicities, racial backgrounds, genders, orientation, that are extremely talented. And it's a question of how do you attract them into specialties? How do you support their education and career development? So one of the things that we've done is through the largesse of the Leon Levy Foundation, a private foundation in New York that funds a variety of different socially worthy causes. We've established what's called the it was actually named after June Jackson Christmas, who was the first African-American Commissioner of Mental Health for New York City. And the program has funded to identify medical students of color and bring them to New York and give them a summer fellowship, all paid and everything, in what it's like to work in the field of psychiatry as a way of drawing people into it. Been enormously successful. No reason it can't be extended across medical specialties, and the number of slots that could be supported really just depends on the amount of funding. So this is something which is an investment in the future, but it's a very good investment.
Dr. Harris, you have a suggestion for us?
I do, but I first want to add a little bit of context. And when I was inaugurated as AMA president in June of 2019, I said that one of the things I wanted to do was amplify the need for diversity in the physician workforce, where the faces of physicians match the faces of our patients. But I said that, and I wanted to make sure that diversity wasn't the end point. And of course, a present company accepted. I'm hearing, I think, too many people talk about diversity as the end point, as if we just need to get a certain number or more of a certain number, and that is the goal. The goal is health equity. And we know that when you have diversity, whether that's in your boardroom or your hospital or your departments, you are stronger, right? And your work, and you're better able to serve our communities because our communities are diverse. So I want to make that point, we have to talk more than just about diversity. And that's why you hear people talking about diversity and equity and inclusion. But diversity is a step, or is a piece of the puzzle. And there are certainly longer term, I so agree with Jeff that we really have to start early. And of course, I am biased here as a child psychiatrist, but I believe we need to start with early childhood education to give our youngest the skills that they need to succeed in school. Because in order, again, to move ahead, you have to succeed in school. So I'll start there as something we can do now, but that will certainly have a longer term return on investment, if you will. And then we can look at right now at admissions committees, and are they diverse? I mean, that's something maybe midstream, and how admissions committees to the health professional schools are choosing their students. That's something. And then right now we can make sure that we are having conversations around equity and inclusion to make sure the faculty that we have right now in all of the schools and all the health professions, we're mainly talking about health today, feel that they are a part of the community, the academic community. And that when they are asked to do work in this area, it is not add-on work. It is valued regarding promotion and tenure. And it is, valued as an area of scholarship. So those are three things that we can do. I consider, the work that we have to do in all areas, sort of upstream, midstream, and downstream. And so those are three. You asked me for one. I'm sorry. I cheated a little and gave you three.
Linda, I wonder if it would be of interest to the listening audience or the viewing audience to expand a little bit on what health equity is, because we use the term, but it may not be. It's something that I'm learning more about. But I know this is something that's really near and dear to Patrice's professional heart. But maybe she could say something, and I'd like to add one thing.
Sure.
Well, sure. There are many definitions. In fact, many in the audience, or so many in the audience may know that at the AMA, we created a Center for Health Equity a couple of years ago. And I was on the task force that looked at even making that recommendation. And we debated a lot about the definition. And then we decided that the best definition is a very simple definition that is hopefully clear and gets the message out. And so we you just defined it as optimal health for all. But you heard me say earlier that we have to create those equitable opportunities for everyone to achieve their optimal health. So I think that is what equity is. Everyone has the opportunity to achieve their optimal health. But Jeff, what you may need to achieve your optimal health may be different than what I may need and what Linda may need. And that's, I think, where we need to have more conversations, because for so often, I would say, we look and tend to look for one size fits all approaches. If we give everyone X, Y, and Z, that should get us to where we need to be. But I think if we are thinking about equity and health equity, we have to appreciate, again, the different needs, and your needs may be different than mine. At the end of the day, both of us, all three of us, should be able to achieve our optimal health, but what it takes to get us there may be different, and that we should be thinking about providing whatever is needed for everyone to achieve their optimal health.
So when we're talking about optimal health and we're talking about COVID, we talked about the statistics in terms of people of color, both, becoming infected at a higher rate and dying at a higher rate. What about the mental health effect of COVID on communities of color? Can each of you talk a little bit about that? Do we have any data about how communities of color are impacted to a greater or lesser degree, or differently even?
At this point, I don't think the data have fully emerged yet, because this is it's like a storm that's coming, or a tidal wave that's coming, but it's going to be in slow motion, and it's going to gradually be manifest. So traditionally, populations of color are not seeking out mental health services until it's really bad, until their symptoms are at an extreme stage. So people now are simply bearing up under the increased pressures and consequences of COVID, and until they reach a breaking point. But you're already seeing things like in domestic violence, in suicide or overdoses, in criminal violence that are occurring, in substance abuse. So these are the kind of canaries in the coal mine, so to speak. Generally speaking, there's a lot of systemic deterrence to communities of color, people of color seeking mental health care in the traditional ways, until it gets so bad they are brought to emergency room, or somebody brings them to see a doctor. But it's going to increase, the denominator is going to increase in the various conditions. And the question is rather than waiting for the traditional pathways to care to be accessed, can we get out in front of it and preempt that, and also bring care to people more rapidly than otherwise would be the case? And that's part of the opportunity that I think we have here.
Dr. Harris, do you want to comment on that, on the mental health impact on communities of color?
I absolutely agree that the data is emerging. And unfortunately, just as we did not have complete data on race and ethnicity, gender, and I always include zip code regarding COVID, we certainly don't have the data on mental health in general, and in particular, we don't have the data regarding race and ethnicity. So hopefully we will get that data. It will likely be incomplete, but we will be able to get that data. But while the data is incomplete, the narratives are emerging, right? And I just looked at some studies that show that African Americans are 3 times more likely to know someone who has died from COVID-19. And we've talked a lot about COVID today, as we should. If we also really want to talk about the psychological impact of what's going on in our times at this moment, we have to include issues around race and around policing and the traumatic experiences. And we know from our work in trauma that you don't have to be the one that's directly experiencing the trauma to be affected. And so there's a lot of vicarious trauma. Certainly, that's why I know you all and I encourage everyone to take care of our mental health. And sometimes we have to turn off the TV, but in order to stay informed, we do see things that are really impacting our mental health. We also know that pre-COVID, there were increasing rates of suicides overall, and particularly among Black and Brown youth. However, less access to mental health care. So we already knew, again, that pre-COVID, we had some inequities. And of course, with COVID and the disruptions and the grieving and the loss, that's likely, of course, to be exacerbated. So we have the narratives, but as I think I've heard Jeff say, and I say, I don't want to predict, I've heard people talk about a tsunami of mental health. I'm not going to predict a tsunami or anything, but here's what we should be doing right now. And I know you all are doing at Columbia and many others are doing. We need to put in place systems and infrastructure to be ready to address. I mean, this is long overdue, right? This should have been in place before, but now is our opportunity to put in place the infrastructure needed to address these issues going forward.
You know, one of the questions that was sent in, no, go ahead, I'm sorry.
Think of it this way. Let's say there was a meteor storm that produced like a smog that blanketed the country. Everybody that had any kind of cardiorespiratory illness or vulnerability would be affected by it. This is what's happening with the psychic impact of the COVID pandemic and the social and economic effects that it's engendering.
So just piggybacking on that is one of the questions that was sent in advance of the telecast was about loss, about the large numbers. And if we know that communities of color are dying in greater numbers, they're going to experience more loss. What do we do? What's a public health approach around dealing with that kind of grief? Do either of you have ideas or suggestions about that?
Well, the emotions that I think the pandemic have engendered are anger, fear, and grief. And grief is associated with depression. And these are different in terms of what triggers them and also how you cope with them. But there's no question that when all's said and done, grief may loom the largest in terms of how it's affecting people. Because, one of our other faculty member, Patrice, I think you've met her also, Catherine Shear, who's an expert in grief, has wonderful talks on this that are on our website in the COVID section. But the grief is occurring at many levels. Of course, if people had family members that passed, that's the first source. But beyond that, there's a collective psychic grief of the country, because to have a pandemic in the 21st century is somehow anachronistic. You know, these are things that are biblical. You know, they don't happen here. They're medieval. It's apocalyptic. So something that we had faith in failed to protect us, the government, you know, science. And so our confidence, our trust, our security has been severely eroded. Now, I'm going to make a speculation, which I think is accurate, but Patrice will correct me. Traditionally, minority populations, and particularly African Americans and people of color, are less trust in governmental authority and authority institutions. So for those individuals, for those populations, that may be less, of a erosion of it. But many people thought that this is something that was just not possible to occur. It happens in movies, the movie Contagion, or the movie that, science fiction movies, but not in real life, but it's happening. So we're having a loss of loved ones proximal to us. We're having a loss of this conception of modern civilization and our government. And we're also having a loss of a way of life because we can't do anything and we may lose our jobs.
You
And
know,
I'd like to add, I'd like to your question about a public health approach to this. And I would say we need a public health approach to grief, right? And I said last week, I think I was participating in a session at the National Association of Black Journalists and Hispanic journalists. And I said, we are not talking enough about grief. And so, Jeffrey, I'm glad to hear that there's even a webinar on grief. It just occurred to me, we need to do more of that. And we will certainly have to make sure we have culturally congruent webinars, because, and here's, I'm going to speak from my own lived experience about being a Black woman and how we grieve the loss of our loved ones, and we aren't even able to do that today. We can't gather in the ways that we used to. And again, I'm speaking only about my own community here. We can't gather at funerals or memorial services and get together afterwards and love one another and hug one another in person. And so we're grieving our loved ones, and we're grieving our inability for our normal rituals. And I talked about really all of the rituals that we've been unable to participate in, and grieving the loss of all of those. So I think that we should certainly think more about a public health approach to this and talk and support folks through grieving, unfortunately, in a different way.
right. And find maybe some ways to commemorate the loss that we haven't yet thought about, but we need to. We have so many good questions that have come in. So let me turn to as many as we can fit in. And then what I'm going to take the liberty of suggesting, for those we can't get to, perhaps we can ask the two of you to respond to them very briefly in writing, and we can send that out and make that available. Because as I said, there are many good questions. So let's talk about telehealth, because it's booming. It's being reimbursed. For-profit companies have sprung up and are doing well as all of the community clinics and hospital services have all transformed themselves quickly to delivering, remote services. Let's talk about communities of color and what do we know about their use of telehealth? Is it exactly the same? Is it more related to poverty and age, regardless of race, in terms of your ability to have devices, in terms of your ability to use them? What do the two of you think? And is this something here to stay? And do we need to somehow attend to race and ethnicity as we make longer term plans to continue to use telehealth?
Well, the technology for telemedicine has been available for many years, for a couple of decades, but because of just habit and also some regulatory deterrence, it hasn't been embraced. So one of the other possible silver linings is the fact that it was we were forced to adopt it. And what we found is that it really works. So kind of almost overnight, instead of in-person, on-site, face-to-face visits, we've been able to maintain care of people using virtual means of communication. Now, part of why that was enabled was that the government suspended the normal regulations about HIPAA-compliant platforms, payment from insurance and Medicaid and Medicare for virtual versus in-person, and also doctors being able to communicate with patients across state lines where they may not necessarily be licensed. So hopefully there'll be some regulatory relaxation in the aftermath, but it has been adopted. And the good news is that it really works. In fact, it works so well that there's fewer missed visits, and there's greater continuity of care. We don't have studies to show whether effectiveness is equal, but there's no indication right now that it isn't. Doesn't also mean that there can't be on-site, because when people for mental health care are getting either ECT or transcranial magnetic simulation or ketamine administration or long-acting injectable medication. They still are on site, but there's no question that telemedicine is good. And the other, I think, opportunity is that the digital technology that can be utilized with smartphones, when it's proven to be effective, will also be able to be adopted in the same vein. But you mentioned the issue about the different groups of our population in terms of socioeconomics or racial and ethnic factors. And it's also age. Older people are less conversant with the internet and IT. So there may be a need for healthcare to involve providing a minimal level of technical assistance and also provision of something for people to use, but we haven't quite got there yet.
So Jeff mentioned some of my areas of expertise at the beginning of the call, and I'll give you 3 more. I am a relentless problem solver. I am a relentless silo buster, but I'm also a relentless worrier. But when I worry about things, it's worrying about unintended consequences. I love sometimes my staff would get frustrated when I led public health here but I always like to see what are the unintended consequences, not to prevent us from moving forward or doing the work, but so we can be prepared for what might happen and have solutions in place. And so clearly, especially I believe in psychiatry, we've been using telemedicine, telepsychiatry. I was using it before the pandemic to work with, I live in Metro Atlanta, but I was using it to see patients from a clinic that was about an hour north of Atlanta. And so certainly within COVID, this was a great tool in the toolbox to maintain access to care. But certainly, as Jeff said, it's not a one size fits all. Some patients don't like it, right? Some of my patients said, I'd prefer it to see you in person, Dr. Harris. And I have to say, and of course, this will get better in the generations ahead, but there are nuances even that all of us as physicians and healthcare professionals, when I walk with my patient back to the exam room, I'm looking at their gait. I'm looking at their neck to see if they have an enlarged thyroid. I'm doing all those things. And so you don't always get that, but there is so much promise in the use of telehealth. I'm glad some of the regulations were lifted. And what we should do after we get through the acute phase of COVID is to have thoughtful evidence-based conversations about what worked, but what worked as regards patient outcomes. So we should all commit to that. But certainly there's a lot of promise. We can certainly increase access. But as Jeff said, and as in my relentless worrying, technology, and I'll just broaden it a little bit, augmented intelligence, as we said, the AMA, we don't use artificial intelligence. It can exacerbate already existing disparities, either in our senior population, although I have to admit some seniors are more tech savvy, but in our rural populations or those who can't afford a data plan, right? Or only have certain minutes. So we were very glad that the federal government allowed telehealth through the phone. But what we want to do is bring everyone up to that. And so broadband access is important. So again, a lot of promise, but I worry about the peril. And particularly around mental health, I worry about privacy. And I just saw an article the other day about who owns the data and who's using the data. And so I guess another thing that I'm relentless about and rabid about is privacy in mental health and for our patients. And so I think that as we continue to absolutely take advantage of technology, innovation, telemedicine, we have to make sure that privacy and confidentiality is maintained and that we don't exacerbate already pre-existing inequities.
Well, just to give you one more thing to worry about, Patrice, as Linda well knows, there's a lot of private ventures that are entering the mental health care space that are virtual, Talkspace and these different things. These are private ventures to fill a void in mental health care, and filling the void is good, but we don't know what the quality of these are. There's no quality control that can be exercised. And so the technology and the virtual modes of delivering mental health care, which are now, the floodgates are open, so to speak. We need to be sure that it's not populating the area of need with substandard services.
Absolutely. I'll say one more word. I want to get to another question, but I went to a huge tech conference and there was row upon row. I might be exaggerating just a little bit, of all of these innovations on everyone in this space, not necessarily the ones you just named, but just a lot of companies who are innovating around mental health, right? And I asked everyone, I went down row upon row, and I didn't say who I was, I just said, what are you doing about privacy and confidentiality, and who owns the data, and how are you using the data? So, I mean, that's what we have to be. I'll worry about it, and I'll be relentless in asking those questions.
Absolutely. It's certainly an interesting area to think about. You know, we are a huge research department, right? Maybe #1 in the country. Do I have that right? Yes. And we're very proud of that. So we do have a research question. So I do want to get to it. And it is asking you, what steps can mental health researchers take to ensure we are adequately supporting our participants of color? And this is, I think, a really interesting one, right? Because we often talk about most research being done with white subjects. And so, you know, what do we do in that arena to make research more balanced and to make everybody comfortable?
That's a great question. And I'm sorry to say, I'm kind of thinking, casting about in my mind to try and think of an answer. There is data showing how the kind of disparities and iniquities that are operative in healthcare in general carry over into clinical research in ways that are not favorable. For example, if you look at the statistics on, let's say, who receives treatment over objection, who is civilly committed, who receives long-acting medications by race, you'll find that there's a disproportionate proportion relative to their base population rates of minorities, and particularly Blacks, who are receiving these more authoritarian or imposed treatments. In some ways it's good, because they receive AOT, assisted outpatient treatment, which is a more kind of, it proscribes some of your civil liberties, but for a good purpose, but they're getting it for the wrong reasons. So you do see this. And then in research studies, because research studies offer the prospect of care without having to pay, I don't know that this is a fact, but I could imagine that you'll see people of lower socioeconomic status, which of course also includes people of ethnic and racial minority groups, being more motivated to seek care in the context of research for that purpose. And then there's also the issue about cultural bias in assessing things like outcome or diagnosis, and how are those reflected in research statistics. And we just haven't addressed it adequately. Now, I can safely say happily that we're way beyond the Tuskegee experiment phase. There's not outright sort of exploitation based on it, but the more nuanced ways in which there's racial bias are not sufficiently addressed, beyond the fact that the NIH or other sources of research funding are cognizant of the demographics of subjects participating and seek to provide some level of diversity, but it's not necessarily strictly enforced, and it's not always achieved.
So I'll add, and I'll go more upstream, right? Who is around the decision-making table to decide the research agenda? And I will say that at every level, and I'll say that all the way to whomever's funding the research, who is around that table, because I know that some of this is driven by the funding available. So I would say, who's around that table to decide what funding is available. It should be a diverse table. If it's not, either, and then if you have the dollars available, then it's at your particular hospital or institution who's around the table that decides the research agenda. And not finally, there's so many, it's a lot complex, but I'll just add that are there community members? Are there members of the community around that decision-making table regarding what is necessary? What research questions do they want answered? And do they have a say-so? And did anyone even go to the community and ask? So those are also factors about research.
Well, Linda, we're hearing this from somebody who's been in the room where it happens.
Right, exactly. So we don't have much time, 3 minutes. I want to get in one of the other questions that was sent in. Children and schools are a major concern and a source of controversy about, should they be in person, should they not? Regardless, how do we mitigate the social isolation that they're experiencing as well, even if, school is, on Zoom? Is that really enough interaction in terms of their developmental needs? And so what do we, again, have to think about from a public health perspective in terms of the mental health of young children who aren't going to be together, haven't been together for kindergarten, first grade, second grade, very important formative times. And I'll start with you, Dr. Harris, given that you're a child psychiatrist.
Yeah, so this is, such an important topic, and, parents are making heart-wrenching decisions, and sometimes it's not even a decision because they have to work. So let me say this, the first thing is the adults in the room need to do what is necessary to get our children back to school. We all know, we all can agree. What does that mean? Wearing masks, right? Not gathering. It's just the basics, because if we can get the spread of the disease down, that's a great foundation for opening up schools. And then we need to think creatively and innovatively. Maybe we, figure out and fund and resource the schools that don't have the resources, the ability to spread out. Yeah. I just say in Georgia, we have the Georgia World Congress Center. It has a gazillion square feet. That's speaking in hyperbole. And we might need to spread out our classrooms there using non-traditional facilities so that we can have smaller class sizes and they can, wear masks. And of course, we need to make sure they have the resources for that. So I think it's up to the adults in the room to do what we know works, good public health practices, and then give the schools the resources that they need. But absent that, while we're not, let's think also innovatively about that social piece, and that's pods and neighborhoods and opening up smaller neighborhood facilities. So I think, there has to be the will.
That's right.
We can come up with creative solutions.
And it's interesting, but I see that people with means are doing those very things. Right. They're creating pods, they're hiring teachers. Private schools have put up tents, giving students their own chair to carry around from tent to tent. Right. But, we're not doing the same things for all people. And it sounds like you're suggesting that's something we need to attend to.
Absolutely.
So can I ask a final question? We talked just very briefly about children. Let's go to older adults and perhaps houses of worship, churches, synagogues, mosques. They are certainly more than any other group fearful, I think, and taking very seriously needing to be isolated. We know the impact of loneliness. We've learned that over the last few years, how it can affect us psychologically and physically. What, again, can we urge our houses of worship and normal places seniors congregate in the past, have congregated to do during this time? Do either of you have some suggestions around that?
I don't know that I would distinguish religious organizations as being distinct from commercial ones or educational ones. It's all the same. As Patrice said at the outset, the guide on this, it's not like we have one set of guidance for people that are politically oriented, another set for people economically, another set for people who are scientifically oriented. I mean, there's only one set of guidance that really makes sense to follow, and that's the science. So I think the problem that I would see, and this has been echoed by some of the pundits on TV, like Michael Osterheim from Minnesota, is that there's no, the virus is not going to argue with us. There's no negotiation. There are ways, thankfully, that will mitigate and crush the virus, but they require significant inconvenience and unpleasantness. If we don't do it, we're just going to be doing this dance of one step forward, two steps back, and prolonging this thing indefinitely. So when you talk about religious institutions wanting to be together for worship, that's not a good idea unless they're going to maintain social distancing, masks, and increase the number of services so they can spread it out over the course of the week instead of just on Sunday or on Saturday or whenever, Friday.
And outside, and we've seen some folks sort of have a drive-in service, and so we are smart people, and we can do different things. It's not what we like to do, it's not what we are used to doing, but we can do different things. And I know so many leaders of faith institutions have done this. In fact, early on in the pandemic, I think I participated in 4 webinars with leaders of faith institutions, from those who had a lot of resources and already had the capability for services, via webinar, to those, a pastor in West Virginia, my home state, small church, they were just using FaceTime. And so again, we have to, do things differently. That's okay. And I also heard someone say that, it's not about the building, their particular relationship with God or their faith is more than the building. And so I think we should just keep reminding ourselves of that.
And there, if they do, and we urge them as almost a public health mission to reach out and use things as simple as FaceTime, I do think will go a long way in helping particularly older adults who may be in quarantine much longer than other groups. I think that's something we should think about. Let's see, it is 12:04. We've run out of time, but I do promise we're going to try to get some of the other questions answered. We'll put it in, we now have something called Columbia Psychiatric Times that comes out each week. So I'm going to pose on the two of you just to answer a few more questions, and we will publish them and get them out also to participants. So I want to thank you both so much. Any last goodbyes either of you would like to say? I've learned a lot.
I've learned a lot. Thanks for the opportunity. I just admire all the work that is happening at Columbia.
Thank you, Patrice. I'm glad that we were able to get into your schedule to be with us today. I just want to close, Linda, by saying that, what we try and do, apart from our usual taking care of our people and educating and research, is to push the envelope, to expand the sphere of quality mental health care in a variety of ways. And one of the ways to do it is through putting out really high quality, accurate information through events like this, and we're committed to continuing to do it. And then the last thing is that, although as much as I would like to say this is like going to be a one and done, and we can see the light at the end of the tunnel, I fear that's not the case. And as a way of coping with this, apart from the fear of getting contaminated or infected, I think people would behoove themselves to understand this is something they have to realize is not going to be over in any foreseeable period of time. And when it is over, the return to normal is not going to be the old normal. And so this is really a transformational event for our generation, just like the Great Depression was earlier, just like the Spanish flu was, just like world wars are. But hopefully we'll come out of it having learned, and for the better. So Linda, thank you for your moderation of this skillfully, and Patrice for your presentation, and for the organization of this, and for all of the 220 some people who attended. So in the meantime, till we see you next time, be well and stay safe.
Thank you. Thank you all so much.
Bye.